My I also have experience in working with incarcerated populations. I've done reentry program management and gone back into the prisons and worked with women and men for well over 15 years. So that's just a little bit about who I am on the call with you. And as Christina mentioned, I would also like to highlight that last Friday was National Women and Girls HIV/AIDS Awareness Day. And the theme for this year was prevention and testing at every age and care and treatment at every stage. And two of those goals was one to the prevention of new infections and improving health outcomes for individuals who are living with HIV. So my question is, how do we meet those goals? And the answer to that question is that the conversation starts here. So I definitely appreciate the opportunity to be in your presence and for us to be able to start this conversation. So I have three objectives for today, and one of them is to promote awareness of the importance of discussing women and girls and HIV, to promote normalizing conversations about sexual health with women, and to provide tips on talking to youth about their sexual health. And so Walt Disney said the way to get started is to quit talking and begin doing. So after this conversation, hope that I will have given everyone some motivation to get out and to do something, to be a part of the solution. And oftentimes I know that people want to do something, but they may not know what to do. But any little bit, helps. Being an advocate, sharing of information. It could just be sharing a flyer about an event. Any of that is helpful. So know that any little bit that we all do collectively can be a big piece. And so the first thing that I would say is for us to know the facts. Now, one thing about Karen is she is a realist, and I do like to speak from research, but in my field and in working in human services for so long, I do like to speak a lot about the reality of what I've seen and what I continue to see in my daily activities of work. So I just wanted to give you all just a little highlight about women and girls in Alabama in terms of STD and HIV rates. And this information was captured off the Alabama Department of Public Health's website. And I'm sure you all are very familiar with that. But I do just want to highlight in this particular report, I pulled from January to September of 2022. And I always tell people to keep in mind that anything after 2020 may not absolutely be, correct, because people weren't able to be tested. As such, people weren't going to the doctor. A lot of different things challenged our data in 2020, and just trying to, move forward from there. But there were 15,685 new STD cases among female, and 27 of those were less than 10 years old. 190 were aged 10 to 14. Over, over 6,500 were aged 15 to 19, and over 8,700 were aged 20 to 24. So I think that says a lot about the individuals that we serve, that we know that they are a primary population for us to definitely be concerned about. And so some STDs like gonorrhea and syphilis can increase the likelihood of getting or transmitting HIV. So even though those STDs were not HIV, the likelihood of someone that has repeat STDs, we can assume that they are not using protection, and it could definitely increase their likelihood of acquiring or transmitting HIV. The HIV new diagnosis came off of the preliminary fourth quarter surveillance report from October to December of 2022, and there were 92 new HIV diagnoses, one less than 13, 17 between the age of 13 and 19, and 87 between the age of 20 and 24. and one is too many within any age group. So I want to just put that out there. And then when we look at the United States as a whole, I pulled a fact off the CDC website that says in 2019, 21% of new HIV diagnoses were among youth age age 13 to 24. 88% of those were males and 12% were young women. Another reason to be concerned. And when I looked at ADPH, and they're looking at barriers to health care, to HIV care, these groups were included in their key populations. That's Black women, cisgender women, all races and ethnicities, and transgender women and youth age 13 to 24. I think, again, those key populations fit those individuals who we are, are trying to service. So when we look at why is it important to discuss women and girls and HIV, one reason is that women and girls make up a quarter of all of people living with HIV in the United States. And we do know that African American and Hispanic women are disproportionately affected by HIV, as are transgender women. So when we look at some of the issues that affect our women specifically, we can look at some gynecological issues. Sorry for being tongue-tied. The increased risk of cervical cancer, and also the perinatal transmission of HIV. We can look at birth control and family planning, prenatal care. Women living with HIV, risk of heart disease is 3 times greater than someone who is not living with HIV. Intimate partner violence, and I'm going to talk a little bit about each one of these. The lack of knowledge of partner status, and transgender women, and their lack of ability to access gender affirming care. So when we look at those gynecological issues, some prevention options to promote better outcomes are one for us to create and increase opportunities for testing. So that is when I'm saying, what can you do? If you have an organization and you can allow us to come in and do testing, we can do anonymous testing. We can create opportunities where we have small, intimate testing events to promote more people getting tested. We can work to increase condom use. And how do we do that? By normalizing it. I pride myself because I have finally been able to talk someone into putting condoms on their desk. And so, people, they think that this might like, wow, you actually want me to put condoms on my desk? Well, yeah, if you have clients that come into your office that you think may need them, yes, put them on your desk, just like peppermint. And you can put them in the same container. Somebody said, what is this? It's condoms and candy. So if I come in your office and you have peppermint on your desk, I'm going to say, well, it's okay for me to get some peppermint. The same thing as a condom versus me saying, Miss Christina, can I have some condoms? And you got to reach down in your file cabinet and get them out. So we got to, work and create ways to increase condom usage, put condom dispensers in bathrooms, where we know, people are going to be so that they can access them. I was in the store the other day and I walked over to look and see how much the condoms cost. And so for someone who may lack, finances, that could be a pretty expensive piece. And by the way, I have plenty of free condoms. If you need some, let me know. Um, Birth control and family planning. So for a person that has HIV, and I'm not a clinician, so I won't go into detail, but it's important that a person that's living with HIV understand what type of birth control will work for them. And that means that they got to talk to their provider and be comfortable doing this. So in their family planning process, they can be successful. Okay. Prenatal care. It's imperative that we get people into prenatal care early so that they can be tested. Now, I'm not abreast on every state on their opt-in or opt-out, testing, but that is something that when I say know the facts, that is something that we all need to know. but I know that women in Alabama are tested at usually at their first prenatal visit, but it depends on how far along they are. I think if they're tested at 6 weeks, the test does not, if it's positive, they don't need a confirmatory. If they're tested at 4, they'll still need to get a confirmatory. And if a female goes in for labor and has not been tested, they can do an instant test on their person. But we know sometimes babies come quicker than anticipated, and it's not always, we're not always able to do everything that we can for them. So when we come in contact with a woman who is pregnant, a young girl, it is important that we try to um, engage them in prenatal care as early as possible and try to help remove any barriers that may be preventing them from getting prenatal care. When we talk a little bit about intimate partner violence, I recently did a presentation on that. And so when we look at a woman who is experiencing intimate partner violence, she may be more prone to participate in risky, more sexual risky behaviors without the use of protection. And one of the things that I discussed with someone in a training 2 weeks ago, and I thought it was very interesting, they said, women are just so trusting. And this is not research, but I think that has a lot of validity, and that we have to work to empower each other to take control of our own physical bodies and not being afraid to ask our partner or potential partners about testing, but oftentimes that doesn't happen because of fear of rejection or fear of being accused, or just not wanting to talk about it. And as I said, when we look at transgender women, we really have to consider them in not being able to access gender affirming care. And the more transgender individuals that I meet and the more I work in this field, I understand the importance of us not being judgmental and not allowing our own biases or cultural or religious beliefs to hinder us getting care and helping them get access to things that they need.
Karen, I just have a quick question, if I can ask real quick, about the intimate partner piece. I imagine that you see, I don't know if you guys like do dual screening for intimate partner violence along with your HIV testing, but I imagine that if somebody is in a relationship that's not healthy or not safe, that they also are at a higher risk for HIV, not because of anything, but because their partner probably won't use condoms, or certainly if there's sexual abuse, probably isn't using condoms. And so I just wonder if that's also part of kind of what you see in your work.
Well, sometimes it happens because, when we get in the room and, a person will, but that's up to you. You have to make that person feel comfortable. And I pride myself on, on that. And I have not too long ago had a transgender woman come in, and she admitted that her partner was, kind of dominating, and did not want to use condoms. And so, at that point, what I do is share the information that I have available, as far as what preventive methods are out there. We talked about PrEP. I also gave her information if she felt like she was in a position where she needed to reach out and get help. And so that's one of the things too, is like, well, we do HIV prevention, but I also work really hard to establish partnerships with other community agencies so that I will be aware of what is going on, because you never know what the person is going to tell you.
Yeah.
And while we can't save everybody, I feel like if I do have information, like I keep little leaflets for the Family Justice Center and the 211, here. So it's in the building.
Yeah.
So we're not just stuck on just the thing that we do, but we do see that sometimes.
Karen, I
So,
also wanted to tell you that we have about 9 minutes left.
okay.
I
Okay.
wanted to ask, Megan had the good idea of, if we get booted off, would you want folks to just click the link and come back in, or what do you think?
I'm okay with whatever y'all need. I can kind of I'll get to this part. I think this part right here is kind of important.
Okay.
Um, because I know that everybody works for so you saying you could start the Zoom over?
Yeah, so if
Oh,
we
okay.
when we get booted off in 9 minutes, if folks just want to re-click the link and
That's fine.
come right back in, and Karen can continue. And if you can't come back in for whatever reason, Megan has dropped the evaluation link in the
Okay.
chat, so encourage you to look for that. But we're gonna get booted out in about 8.5 minutes, and we'll just jump
Okay.
right back in with the link that you received in your email. If
We
everyone
can,
can do that.
that's fine. We can do that.
Okay, let's do that.
So I'm going to move on to objective 2, which is to promote normalizing conversations about sexual health with women. And I use the term, I like to use the term sexual health because it encompasses the whole us. And as women, I feel like we are more vulnerable and susceptible to things. So I talk about, I can't talk about our sexual health without talking about sex. So, we have to be able to be in tune with our own sexuality. When we're working with clients, need to evaluate and reevaluate ourselves in our comfort zone. I'm grateful, sex is my work life. So that's what I do. I can't go out and talk about STDs or HIV without being able to talk about sex. So it's important that when I'm out and in front of people, that I'm comfortable talking about it so that I can engage them. And so, I say, so when is it okay to discuss a person's sexual health choices and or lifestyle? So if you are a case manager, when is it okay for you to talk to them about that? So there are a couple of ways, and I'm just using case management for an example. So when it's obvious that a person's sexual lifestyle is interfering with your ability to help them reach their targeted goals. So what do I mean by that? If they say you have a client that has a small arm baby, okay, and then they present to you and they're pregnant again, and they're pregnant again, but they're not happy about the second pregnancy, and they tell you that, hey, I just wasn't trying to get pregnant. I don't know how I'm gonna take care of this baby, and blah 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 blah. Boom, it's okay because the way they got pregnant is something where you can start the conversation about, well, do you have plans for what are your plans for not getting pregnant after you have this baby? We every situation is going to be different, but it's okay because if they continue to have, multiple children that they can't take care of, they're going to increase barriers for what you're trying to do to help them reach their targeted goals in your program. So it's okay then. Watch for cues. Listen and be intuitive when a client reaches out to you directly or indirectly. Um, Create a welcoming environment. Um, Make sure that you're approachable. Make your office space warm. It doesn't have to be decorated like your house, but create an atmosphere where when people come in, it's like, I like coming into Christina's office. It just feels so serene, and I just feel like I'm at home. And so, create that find literature that's appropriate for your office space. Again, we talked about having condoms readily available and accessible. So, and what about if a client cannot make their appointment and they say they went to the doctor, but they don't want to give you a doctor's excuse because they really didn't go to the doctor. They went to the STD clinic and they don't want to give you a, a, um, a clearance from the health department. Well, you finally talk them into it and you get that. Well, guess what? Next month, same thing. So, okay, this person has been tested for STDs last month and this month. So let's talk about your frequent visits to the health department, you know, um, and being aware of, like I say, of intimate partner violence. When a person does share some information with you, uh, being able to, start a conversation, because I know that everybody doesn't feel comfortable talking to a person and they feel like, well, I'm not going to touch that part of that person's lifestyle, but that part of that person's lifestyle is hindering you from being able to help them fulfill their potential. So again, it's why I like to use the term, sexual health, and repeated STDs will only lead to something that they can't get rid of. It could be herpes, genital warts, or HIV. So if a person is just not using protection, continuously being infected, it is definitely going to impact their overall health. The last objective that I wanted to go to was about talking to our youth. Um, Provide tips on talking to youth about their sexual health. One of the things that we need to do is we got to work on learning the language that youth talk. If you're a parent, caregiver, friend, or whatever, look on their Facebook pages, their Instagrams, their Snapchat. Use opportunities that you're talking to you about about what they say. Like when I worked in the school, I asked the guys. I said, "So, how do y'all let a girl know y'all want to have sex with them?" And they told me what they say. So okay, so when y'all having this conversation, that's what you all are talking about. So I need to be aware. Also too, they're young, meet them where they are. Create opportunities for them to express themselves, for them to say what they need to say, for them to, even when they use inappropriate language, use that as an opportunity to teach them. I had kids that didn't want to say vagina and penis. They said it didn't sound right because of the culture and the home that they were brought up in. So allow them opportunities to express themselves without chastising them. Research information and stay informed. Create rapport with them and trust. And I think these are two of the most important. These are some of the taglines that I like to use with parents is that one talk won't, but one time will. So we can't just say, oh, well, I talk to my kids or I talk to the kids on my caseload and they know about sex and we had a class. No, it needs to be multiple times. Also, too, I would say prevention is not permission. And that is one of the issues I think we have with kids and parents, is that they think if I talk to my child about birth control or condoms, I'm giving them permission to have sex or participate in these behaviors, but that is not true. So another area that I'm really working on is trying to reach out to parents. And then when I say to us, are we ready to talk to our youth about sexual health? A couple of things that I will say is again is stay informed to identify unique ways and opportunities to talk to youth. Be open and relaxed. Don't have just one conversation, have more than one, and to provide opportunities for conversations between teens and their healthcare professionals, because at some point your child is not going to want you to go to the doctor with them, inside the doctor's office with them. So we have to prepare them for that and to avoid overreacting when we hear something that um, we don't agree with, or we think, oh my God, not my child or not the child I'm working with. And these are tips too that you all that work with kids and work with their parents and school teachers and behavior interventionists and such. These are things that we can share with them. I just had a few more tips, but if we have time for Q&A, we can. If not, I kind of tried to make it work within this 30 minutes. And I
You
hope that I've
did a
told you
great
all
job.
something.
So I think we're going to get kicked off